So good morning everyone. Today we continue with our journal club presentations. Dr. Bayan will give us a very interesting talk about the intramedullary masses of the spinal cord. These are common findings we find every day and basically they all look the same. So we need some points to help direct us toward which possible diagnosis is it. So Dr. Bayan will help us with this thing. تفضل دكتور. Okay. Okay.
Bismillahirrahmanirrahim. Our topic now, intramedullary masses of the spinal cord. This is the masses which present within the substance of the cord. First, in order to understand the intramedullary masses, we should understand some points about the anatomy of spinal column. Spinal column is organized in 31 segments with 31 paired vein, which nerves is with 31 paired nerves, which are protected by the intraosseous compartment. And spinal cord extends from medulla oblongata to the level of the conus medullaris at level of ends, which is level of L1 in childhood and upper in adult, and upper level of L3 in child. And it's protected by the dural sac, which extends from upper level to the level of the second sacral vertebra. Also, we have a filum terminale, which continuations of the pia mater at the level of the colon to the level of the first coccyx. This is the filum terminale. It's important to understand some points about anatomy because in the compartment of the spinal cord, which composed of the outer white matter and inner gray matter, we have some tumors which arise from the outer layer white matter, like astrocytoma, are eccentrically located, while some of the tumors which are neuronal in origin, like ganglioglioma, are centrally located within the cord. And spinal column also it is 45 centimeter in long and 1 centimeter. Spinal cord is 45 centimeter in length and 1 centimeter width, and its weight 2 to 3% of brain weight. In other diagnosis or investigation of intramedullary masses, as the other spinal masses, the first modality of the choice is MRI or CT myelogram. MRI is the first modality, and the sequence which we need T1 weighted image with T2 weighted image, also with T1 with contrast enhancement. In some of the tumor, in order to depict the tumor cellularity, we need diffusion weighted image and diffuse tensor imaging. In other CT myelogram also needed in order to, especially in the preoperative evaluation of the tumor, for exact extension of the tumor and cis location. And or in any, when we are interpreting of the MRI or CT myelogram of any tumor, we should know the location of the longitudinal location of the spinal level and compartment involved. And second, we should analyze the signal intensity of the masses, whether it is salt enhancing mass or cystic component which is not enhancing. And we evaluate the tumor margin, whether it is circumscribed or infiltrative. And this is the first, we have intramedullary mass component which cause expansion within the spinous of the cord, and other which are extramedullary, which cause compression on the cord. This MRI on the sagittal T2 and T1 with axial section MRI, which in upper level we show well-defined, well-circumscribed tumor margin. This is important to interpret it in the MRI especially for the neurosurgeon to know whether the tumor either totally resectable or subtotally. In first one, which is well-defined margin, it is totally resectable. While on the lower level, on the sagittal, you have infiltrative tumor at level of the upper thoracic, which is also on the PET fluorodeoxy PET CT scan is hypermetabolic stage, which indicates that the tumor is of higher grade and infiltrative form and cannot be totally resectable. We may need radiation. In Intramedullary masses, they're divided and according to their either neuroepithelial in origin, which divided subcategory into ependymal or astrocytic tumor, and we have a neuronal tumor like ganglioglioma, and embryonal tumor with atheratoid rhabdoid tumor, and other with the neuroepithelial origin, like we have mesenchymal tumor and melanocytic tumor, who have also lymphocytic and metastatic form. We come discuss one on them, and we have non-neoplastic origin, which is either congenitally or acquired, like vascular malformation, and also we have those with epidermal inclusion and ectodermal inclusion or mesodermal inclusion. So first come we search or ependymal tumor. In intramedullary tumor, when we divide 70% of intramedullary tumor, either epindymoma or astrocytoma. So they contribute most of the differential down 70% is either epindymoma or astrocytoma. Epindymoma more common in adult age group, while astrocytoma is common in the pediatric age group population. And in ependymal tumor are slightly more common than astrocytoma, and vice versa to the brain, which were reversed, astrocytoma more common. Ependymal tumor, according to WHO classification, according to the grade of the severity, we have subependymoma, myxopapillary ependymoma, or ependymoma grade D, and the last one is more severe, anaplastic ependymoma, which grades 3 and more severe form. In general, ependymoma, which I said contribute to more in the adult age group, it consists of centrally located within the cord and give heterogeneous appearances, and it is more common in the men and in fourth decade and older life, but may occur in younger age group of population, especially in those with neurofibromatosis type 2. It is heterogeneous appearances due to ability of the tumor to hemorrhage and cyst formation. This is different from the astrocytoma. Well, in 1/3 of them may contribute to the hemosiderin cup. Hemosiderin cup may present in 1/3 of the patient, but it's not pathognomic for ependymoma. It also may be seen in other tumors like hemangioblastoma or other paraganglioma. This patient presents sagittal T2 and T1 weighted image. We show isointensimal, I think, in T2 with enhancing at T1 level segment with non-enhancing upper part, enhancing part and upper part polycystic component not enhancing. This patient ependymoma is hemosiderin cup. This is the hemosiderin cup, which is seen in 1/3 of the patients with ependymoma. This is not pathognomic site because also seen in other tumor. This patient with anaplastic astrocytoma. This patient present with anaplastic ependymoma. This patient is suspected to be neurofibromatosis type 2, as we see in upper thoracic spine and enhancing mass and the level of T2A, with lower thoracic multiple other enhancing mass. Also, we have other extra axial tumor component, either in the internal auditory or cauda equina, which either they are multiple schwannoma or tumor subarachnoid spread of other ependymoma. As we said, this is the patient with neurofibromatosis type 2, which present with multiple ependymoma, schwannoma, or some of them meningioma. Myxopapillary ependymoma. This is a slow-growing tumor. Mainly arise from the ependymal cells of the conus medullaris. It is also has both cystic component and may have tendency to hemorrhage. This is exact location, and we know it's at the conus medullaris or the filum terminali because it arises in this site. This is patient with sagittal T2 and contrast enhances T1, which reveal hyper-intense mass at the level of the conus medullaris with upper pole cystic component which non-enhancing. This subependymoma is also subgrowing. The characteristic of the subependymoma, so it is hyper intense on the T2 weighted image. It has no significant enhancement in contrast enhanced T1, give no significant enhancement. This is a characteristic feature of subepindymoma, and this give steep swelling on the spinal cord, which expansile mass and slobulated, and characteristics gives Van-Bo leaf sign for the spinal cord.
So the difference between epindymoma and subepindymoma is what?
Subepindymoma gives non-significant enhancement, not enhanced like other epindymoma.
Subepindymoma are not central,
Yes.
like this one. It's not from the center of the
Yes, it's from the
of the spinal cord. It's
yes.
paracentral. While epindymoma, it's central.
Yes.
Subepindymoma does not show much contrast enhancement, while epindymoma does show some contrast enhancement.
Yes.
Myxopapillary epindymoma is usually seen where?
At the conus medullary.
At the conus and the phylum terminal.
Yes.
It's from the ependymal cells of the phylum.
Yes.
Okay? So these are the major differences that
Yes,
we should
يعني-
focus on. The bamboo leaf sign, it's a feature of subepindymoma.
Yes.
There is a normal spinal cord and then suddenly swelling and then comes back to normal.
Yes.
Okay?
So this myxopapillary epindymoma also may contribute most commonly as extramedullary compartment than intramedullary because it arises from the
Phylum
ependymal
terminal,
cells.
yes.
And astrocytoma is other category which is more seen in the pediatric age group. It's also organized as WHO classification as periostic astrocytoma, which WHO grade 1, and diffuse astrocytoma WHO grade 2. And we have anaplastic astrocytoma, which is WHO grade 3, and last glioblastoma, which is more severe form, and grade 4. This is periostic astrocytoma. Also, in sagittal city, there is fluid attenuation of cervicomedullary junction, and you have sagittal T2 and T1 weighted images which show there is the significant cord edema involvement with upper enhancing mass at the upper cervicomedullary junction with cystic component, its upper pole.
So there is an enhancing component,
Yes.
a cystic component, and the spinal cord is involved by syrinx.
Yes.
These are all syrinx, dilatation
Dilatation,
of the
yes.
central canal. This is the tumor. Okay?
Yes.
So this is where the surgeon needs to cut. This is just secondary to the tumor.
And edema itself or infiltration?
Edema and syrinx, not infiltration.
Syrinx.
Yes,
Dilatation.
dilatation.
Astrocytoma can be present in the focal or diffuse infiltrative form. According in the adult age group, it's present as more infiltrative form and can differentiate from diffuse astrocytoma, which is grade 1, 2, and a plastic astrocytoma and more severe form and more cellularity. And while glioblastoma is
Just a second, previous slide.
Go to the previous slide.
To Ahmed, usually syrinx cause distally dilatation.
In cases of astrocytoma, yes. It's
I think that usually it is proximal.
yeah, it should be proximal, but depending on the type and the location, it might be proximal or distal.
the astrocytoma is mainly arise eccentrically, and in periostic astrocytoma, either it is, I think it is displaced rather than infiltrate because it is low grade form in periostic astrocytoma. Glioblastoma is WHO grade 4 tumor, and it is present with more heterogeneous appearance in the T1 and T2 and give extensive enhancement. And this is the glioblastoma grade 4, which arise in enhancing mass at the level of the conus medullaris, in both on the sagittal T2 and T1 contrast enhance. This is the main difference between the epindymoma and astrocytoma. As we said, epindymoma mainly occurring in the adult age group, while astrocytoma occur in children. But when it's present in adult, as is said, it is present in more infiltrative form. And scoliosis and bone remodeling are more common in epindymoma, while bone change infrequent in astrocytoma. Central location in the spinal cord is epindymoma, while astrocytoma is eccentrically located. Epindymoma well circumscribed, while astrocytoma is ill-defined. Whenever we see diffuse infiltrative mass within the spinal cord, we first think astrocytoma. Hemorrhage and cyst common in epindymoma, while it's less common in astrocytoma. and associated epindymoma with neurofibromatosis type 2, while astrocytoma is associated with neurofibromatosis type 1. Ganglioglioma is other tumor of neuroepithelial origin, and this is the patient with, I think it causes diffuse hollow cord involvement. It's grade 2 neuroepithelial tumor of the glial cell origin. It arises centrally within the gray matter. It mainly presents ganglioglioma within the cerebral cortex, less common within the spinal cord. And this level, because it arises in neural cell origin within the gray matter, is centrally located. And this gives expansile heterogenic mass detected the tumor, which at level from C1 to T3, which cause extensive cord involvement and is enhancing mass. And sporadic hemangioblastoma. Hemangioblastoma is non-neuroepithelial tumor, and it occurs in third manifestation after the epindymoma and astrocytoma. It occurs in less than 10% of cases. 80% arise from cerebellum. I think hemangioblastoma in the cerebellum, and 20% arise within the intramedullary portion. When it is, because it's high vascular tumor, it has ability to hemorrhage and give a signal flow void due to weighted images. And in quarter of the cases associated with familial von Hippel-Lindau syndrome, and when associated with familial, may be present in multiple locations. There are multiple, not focal. This is the image show intramedullary lesion in the lower thoracic cord and associated with syrinx and flow voice signal. And the other is T1 post-contrast fast saturated image, which demonstrates there is no dilute homogeneous enhancement. Other image, this is sagittal of T2 and T1 weighted image show familial hemangioblastoma. In sagittal T2 weighted image reveal there is edema and signal intensity throughout the cervico-thoracic junction and lower thoracic cord. And there is other sagittal contrast enhanced T1 image reveals there is two large enhancing intramedullary mass at C1 and C2 with C71 level, with non-tumoral cysts at the superior pole. Melanocytoma has leptomeningeal enhancement. Diffuse melanocytoma may give rise to diffuse leptomeningeal enhancement, and this give heterogeneous characteristics and give T2 hypointense signal due to its melanin content. Degree of the signal intensity is depend on the melanin content of the tumor. This is a sagittal T1 and T2 with contrast enhanced T1. We have ISO.
The idea is that on T1 there is some area of hyperintensity.
Yes.
And that's why, because there is melanin. Melanin is hyperintense on T1 weighted image.
Yes.
Okay, so this is the clue. Now, this is rare, very rare tumor, by the way. And on T2 it's just a mass with some cystic component showing some post-contrast enhancement. And you can see it's within the spinal cord, it's intramedullary. And on the operative section, you can see it's black in color. Why it's black? Because it contains melanin.
Lymphoma, we have lymphoma and also with metastasis together. They are rarely occur intramedullary portion, and when they are occur as a secondary and manifestation, not primary. Primary CNS lymphoma is primary intramedullary lymphoma. It accounts for less than 1% of all CNS lymphoma, so it is very rare. But whenever it occurs as secondary, less like primary, and it's mostly extradural than intramedullary portion. In this case, there is a C1 associated with stringomelia expanding from the medulla to the level of the C5, and the lesion appears as iso-intense mass here in on the T1 and T2 weighted images with homogeneously enhancement with post-contrast image. This is the same patient with lymphoma 3 months after post-operatively, which completely not seen, and there is no tumor recurrence. This is metastatic tumor. In the upper one, metastasis set is intramedullary, is most arise secondarily and mainly arise from the CA breast and CA lung. And the level of the C2 here, there is iso-intense mass, which also seen on the well circumscribed. Whenever we have metastatic tumor circumscribed, but they give extensive vasogenic edema. And the same patient also the contrast enhancement, we see multiple foci of the enhancement at the level of the spinal cord, cerebellum, cerebrum, which is metastasis. Cavernous malformation, it's give area of the signal void, which may see area on the hyperintensity with the peripheral hypointense rim due to hemosiderin in the T2 weighted image. Also not give significant enhancement in the cavernous hemangioma. On the other tumor we have
Why no significant enhancement?
slow flow
Because
void.
it's slow flow. It
Yes.
is vascular, but slow flow.
Yes.
So the enhancement is not very obvious. You can see multiple serpiginous flow voids
Yes.
here and there. This is an AVM, arteriovenous malformation, not a cavernous hemangioma.
This, yes. Intravenous is IV malformation. In image show multiple signal void within the cervical spinal cord, consists with intramedullary IV malformation, and there is long draining vessel, and the other is CT angiogram, vertebral artery, confirmed MRI finding. Other tumor which arise from the ectodermal inclusion, we have epidermoid and dermoids. And epidermoid gives rise to CSF signal intensities. It is because of the has keratin content, and it is different from it is restrictive, restrict diffusion in diffusion weighted image. This is the epidermosis in CT, which gives hyper signal intensity on both T1 and CT, and it is hypointense on the T2 weight image. Either it is due to blood content, I think. Protein content, yes.
So it's hyperdense on the CT scan because of the high protein content. On the MRI, it's hyperintense on T1 and hypointense on T2.
Yes.
Why? Because of its high protein content.
Yes.
Okay. While here, what's the difference with this one?
The dermoids give heterogeneous appearance. Yes.
Why dermoid?
Because of
it has
fat content.
fat signal intensity. You can see on the CT scan there are hypodense areas within the lesion that are hyperintense on T1 and on T2. This is dermoid. So whenever you see fat within the lesion, this is a dermoid.
Yes.
Okay?
And differ from that also give homogeneous enhancement, while dermoids heterogeneous enhancement because of the sebum content. That tumor we have lipoma that arise from mesoderm inclusion of the cyst. It is differential diagnosis is subacute hematoma, but it's different from that. It's suppressed on the fat suppressed MRI. This is the T1, T2 with stir and fat suppressed MRI, which so hyper intense T1 signal intensity with homogeneous enhancement, and it's dropped on the fat suppressed MRI.
So whenever you see hyperintense on T1 and T2, do a fat saturated image.
Yes.
On fat saturated, loss of signal indicates fat content, and it's only lipoma. You have nothing else.
Thank you.
Thank you very much.
Now. Yes.
If I'm not mistaken.
Question.
So-
Most common intramedullary tumor. Most common intramedullary tumor, as we say, 70% they are epindymoma and astrocytoma. Most common intramedullary tumor involve the conus medullaris. It's myxopapillary epindymoma. Which type of epindymoma has both intramedullary and extramedullary location? Type of epindymoma, the other tumor we have, but type of epindymoma is also myxopapillary epindymoma. Yes. Spinal intramedullary tumor associated with von Hippel-Leydig syndrome. Glioblastoma.
Good.
Most common spinal lesion. I don't see intramedullary. This is the question. And spinal lesion is most common is extra.
Extramedullary is
And
more
most
common.
common, yes, most common disc herniation. Most common primary intraaxial tumor with brain and spinal cord in childhood. Astrocytoma. Thank you.
Good. Very good. يعني بس التلفزيون بقى يكون ما عندهم بس التلفزيون